Now we're live.
Now. All right. We call
I'm still
the roll.
managing stuff, so can we hang on for 1 second
Yeah.
while I'm okay?
Yeah. Happy New Year, everyone. Thank you.
Hey, Jen Kennedy, will you please raise your hand so I can change your name? There we go. I don't mean to hang things up, but this is important. Trying to get all the public commenters ready to go. All right. Thank you, Jen. You can put your hand down. All right, I'm ready. We can start.
All right. Can we just call the roll, please?
Absolutely. Appreciate everyone's patience. Devin Consagra.
Here.
Jeff Bortner.
Here.
Matt Sears.
Matt has not made it today.
Okay, thank you.
Lisa Cruzes.
Lisa Cruzes. She's not in.
She won't be
Okay.
here.
Max Kaiser.
Here.
Mike Collins.
Here.
Ben Hoffman.
Here.
Larry Lyon.
Here.
Linnea Lindsay.
Here.
Stacy Geisler.
Here.
And Mark Buckholz has raised his hand, and I'm about to make him a panelist, so we know that he is here. And I believe Chris Pinzon is absent.
Right.
We have a quorum. Thank you.
Yeah, great. Nice to see so many of you in person here. Okay, so minutes.
Can we just go the testimony?
Oh, no, not even do the minutes. Sure. Yeah.
We'll do that.
Okay.
So we have some commenters here need to leave before 2 o'clock, so want to get started right away with public testimony. So we'll delay some of the staff report and the orientation slides. But we have some people here to comment on our consent agenda items. Daphne, whenever you're ready to.
Thank you so much. This topic might be sensitive for some people, for a lot of people, it could be. As a reminder, HERC is a policy-making body and cannot make decisions about coverage or care for individuals. Any policy changes resulting from today's discussion go into effect at a future date. The discussion might be personally intensely personal for some, but in this forum, we tend to discuss things that can seem clinical and impersonal. And not every person's experience will fit into the picture that the clinical evidence shows. Please be aware that our process, the Commission's business, is to make the best possible decisions for the general population using the methodology and processes to determine the importance of services. So based on the number of people we have signed up today, we're allowing 3 minutes for each person to testify. Liz will put up a timer, and a progress bar will show how much time is remaining. And then after your time ends, if you could remain in the meeting in case members have questions for you. When I make you, when I press the button that allow you to talk, if you could state your name, any conflicts of interest you have regarding this topic, and your affiliation. We're going to start today with Paul Turdal. Let me find you, Paul. There you go. Mr. Turdal, you have the floor.
Great. Thank you very much. So my name is Paul Turdal. I'm a volunteer health consumer advocate for individuals with autism and other disabilities, and the father of 2 adult autistic children who have benefited from ABA. My children and I are all OHP enrollees. I do not have any direct conflict of interest in this, in this particular issue, and I'm not receiving any compensation from anybody. I'd really like to begin by thanking HERC and all of you for the decision a dozen years ago to cover ABA for autism and self-injurious behavior. Your decision then made a huge positive difference in the lives of thousands of autistic Oregonians and the families, including my own family. To give an example, one of my children underwent significant autistic regression as a toddler, becoming entirely nonverbal, scoring below the first percentile in communication skills with below average IQ. After a year of early intensive behavioral intervention, a form of ABA, his ability to speak was restored, his IQ was better assessed at well over 130. Today, while he remains significantly impacted, he is graduating from high school and looks forward to a very bright future. HERC helped make that possible, so thank you. When you look at your staff report, which talks about some of the costs, please just bear in mind you're getting something for your money. There are, I think I saw more than 7,000 autistic families benefited from that service in 2024 at a cost of about $7,400 a piece. You're getting something for that. As you look at this issue, I know the evidence is not stellar. I have done a lot of work in the pharmaceutical industry. I know what the pharma industry does in terms of developing RCTs and things. You're not going to get that here because the cost would be prohibitive and nobody's going to get a patent and monopoly pricing, if they're successful. A year ago, Dr. Consagara was quoted by the Lund Report basically pointing out that when evidence is weak, for things, we rely to a greater extent on clinical experience and values and preferences of the individual being treated. That's really what you should do here. And fortunately, you have a number of real experts on ABA therapy and intellectual and developmental disabilities who have reached forward to testify to you and give you some input. And I would really encourage you to look at that and really to continue this conversation beyond this meeting and looking at the expert input from the subject matter experts. So again, thank you very much for your time and thank you very much for your past work on this issue. Thanks.
All right, I think we can, thank you, Mr. Turdal. I think we can go on to the next.
Thank you. And next, I'd like to invite Kimberly Hook to give her testimony. If you'd like to come forward.
Just for the record.
Can you do a mic check as well, so make sure you can hear.
Where the mic is
The
actually.
mic's right here, just go ahead and speak and we'll make sure they can.
Hello. Can folks online hear? Yeah, thumbs up, okay.
Okay,
And
great.
just for our records, if you could state your name, any organization that you might be representing, and none is fine, just
Sure.
yourself, and then
Okay.
any financial conflicts of interest.
Okay, I have no financial conflicts of interest. My name is Kim Hook. I'm a parent of a child with Down syndrome. Is that good?
Perfect.
Okay, all right. Thank you, members of the HERC Commission, for hearing my testimony today in support of ABA services. My name is Kim Hook, and together with my husband, John, we are parents to our 12-year-old son. He has trisomy 21 and an intellectual disability. He is capable, intelligent, and eager to engage with the world, but he faces severe behavioral and functional challenges that impact every part of his daily life and our family's ability to function safely. When our son becomes distressed or can't access preferred activity, he engages in intense behaviors, hitting himself, screaming loudly, and escalating quickly. Even our best efforts with calm words and reassurance often aren't enough, and these episodes can last a long time. Transitions are especially hard. Leaving places he loves, like an arcade, pool, or trampoline park, can take 30 to 45 minutes or more, causing deep distress for him and disruption for everyone around us. These moments happen multiple times a day, whether we're leaving a store, an activity, or even our own home. The emotional toll on our family is heavy. We often feel defeated and hopeless despite doing everything we can. These behaviors have cut off our access to respite care entirely. My extended family no longer feels safe or equipped to watch him. Paid support workers can't manage his transitions or distress, and several times they've called us to leave work and pick him up because the situation became unmanageable. The constant stress has forced me to take FMLA just to keep up with caregiving. Education has been affected too. This year, our son had to leave brick and mortar school because the environment overwhelmed him and the school lacked the right strategies and supports. He shut down repeatedly each day, blocking any real learning. Now his education and care fall entirely back on us, adding more stress and limiting his chances to grow and gain independence. Applied behavioral analysis offers evidence-based tools to help. It would teach our son skills to transition more smoothly, communicate better, regulate his emotions, and reduce behaviors that interfere with learning in daily life. Just as importantly, ABA would give our family support workers and educators consistent, predictable strategies so he knows what to expect and can succeed everywhere. That consistency is essential for real progress. Without this intervention, our son's challenges severely restrict his safe participation in family life, school, and the community. Our biggest goal is his independence to one day live, work, and contribute as an adult. ABA isn't optional. It's a medically necessary treatment to build the foundational skills he needs to get there. Right now, families like ours are often offered only medication, which doesn't teach skills, promote independence, or address the root behavioral needs. I respectfully urge the Commission to ensure individuals with intellectual disabilities have the same access to ABA services as those with other diagnoses. Families deserve evidence-based options that truly improve quality of life and long-term outcomes. Thank you for your consideration.
Thank you for sharing that with us and for being here. We appreciate it.
Sure. Thank you for hearing me.
Any questions?
Thank you.
Are we ready to have our next person come?
Very nice to meet you.
Yeah. Thanks, Stephanie.
Thank you. Next, we'd like to invite Gina Green. Gina, I'd like you to state your name for the record, any potential conflicts of interest you have, and any affiliations. I'm going to press the button right now, and the floor is yours.
All right, thank you very much for this opportunity. My name is Gina Green. I have no financial conflicts. I'm currently an independent consultant in private practice, a board-certified behavior analyst doctoral, former president of the Association for Behavior Analysis, retired CEO of the Association of Professional Behavior Analysts, and co-author of the book Strategies and Tactics of Behavioral Research and Practice. A lot of my 40-year career has been spent developing, overseeing, and evaluating behavioral interventions for people with intellectual and developmental disabilities, training practitioners to work with those populations, contributing to evidence-based practice guidelines and standards, and working on public policies around health insurance coverage of applied behavior analysis services. So I'm offering these comments actually in follow-up to written testimony I submitted to the HERC earlier, and in support of testimony submitted by the Oregon Association for Behavior Analysis and others. I'm sure that members of HERC are aware that advocates of evidence-based medicine have long advocated for basing decisions about the healthcare of individual patients on the best available external clinical evidence from systematic research. A large chunk of the evidence on interventions for building adaptive skills and reducing challenging behaviors in individuals with IDD comes from studies of ABA interventions using single case experimental designs. These are designs that enable systematic controlled evaluations of the effects of interventions on the behavior of individuals. Replication, which is a cornerstone of science, is built into the designs. Additionally, evaluations of the effects of many ABA interventions have been replicated hundreds of times in studies published in peer-reviewed journals over the last 50 plus years. Meta-analyses of data from multiple studies using those designs document the efficacy as well as the magnitude, the reliability, and the generality of those interventions. There are several entities that recognize sound studies using single case experimental designs produce strong evidence about interventions. So I would end by, again, thanking you for this opportunity and really strongly encouraging the HERC to include a careful review of the research on ABA using single case experimental designs in their final decision making. Thanks again.
Thank you very much, and thank you for your work.
Certainly.
Thank you. Next, I'd like to invite Jen Kennedy. One moment, Jen. If you could start by stating your name, any conflicts of interest, and affiliations you may have, the floor is yours. Thank you.
Hello, members of the commission. My name is Jenny Candidate, and I have no conflicts of interest. I am a disability advocate and parent of a fine young autistic man who is a non-traditional communicator and was denied mental health care for years due to his diagnosis. I am here to urge you to listen to the survivors who speak out against ABA. When my son was young and struggling with his mental health, the only intervention that was available to us was applied behavior analysis, which is a behavior modification modality that does not look deeply into why a distressed behavior may be happening, and instead focuses on modifying the externalized behavior and training autistic children into compliance and conformity. ABA often takes credit for the natural progression that children go through as they age, which leads to false data, something that plagues ABA for many reasons. This intervention is now well known to cause PTSD, but back when it was brought to me as the only option, I was not given informed consent. Parents still do not get informed consent around the potential for PTSD. That needs to change. I ended up pulling my son out of ABA because it was inhumane and only made things worse. The attempt to break him like a horse and train him like a dog had failed. I was told that he would not benefit from mental health therapy because of his disabilities, but in truth, they would not consider him for this option because of ableism, which was showing up in the form of a lack of ability to presume competence. Unfortunately, my son is now one of the thousands upon thousands of ABA survivors who've been diagnosed with PTSD. It was not easy. There were many, many barriers in the way, but eventually I found a skilled and experienced mental health therapist who was willing to see him. With the removal of applied behavior analysis interventions and the addition of robust neurodiversity affirming mental health care and sensory supports, he began to heal. He is now a happy and thriving adult who goes to work every day and enjoys recreating with his family. With the right help, he has become masterful at managing his PTSD triggers. He is wise and kind and more insightful than most. If we would have stayed on the behavior modification track, I believe my son may have died from headbanging and or been institutionalized. Seeing him as a whole, thinking and feeling human and honoring his need for the same mental health supports as anyone else saved his life. If we are truly here to unpack systemic ableism, we must ensure the IDDD community, which includes autistic children, has access and choice when it comes to true mental health care. This is their human right. I can't help but notice that the majority of written testimony you received includes a conflict of interest because it is coming from those whose income depends on the ABA industrial complex. Thank you.
Thank you very much. Thank you for sharing your story.
Thank you, and I'm sorry I mispronounced your name, Jenny. Next, we'd like to hear from Nicole Neal. If you would like to state your name for the record, any potential conflicts of interest and affiliations, the floor is yours.
Thank you. My name is Dr. Nicole Neal. I'm an Associate Dean of Research at the Faculty of Education at Western University, as well as a member of the Board of Directors for the Association of Professional Behavior Analysts, and I have no financial conflicts to declare. Okay, thank you. So I'm speaking from my expertise as a researcher and a clinician, and on behalf of APBA. I bring more than 2 decades of expertise in applied behavior analysis for individuals with intellectual and developmental disabilities, including Down syndrome and other genetic and developmental conditions, as well as cognitive behavioral interventions for mental health concerns among autistic individuals. Applied behavior analysis is safe and ethical and evidence-based approach for individuals with intellectual disability, and the scientific record strongly supports its use based on individual need rather than diagnosis. Many of the studies that investigate supports for individuals with intellectual disability include multiple or overlapping conditions, such as genetic syndromes like Fragile X and Angelman and Williams, often with co-occurring communication, behavioral, and medical complexities. The evidence base for ABA explicitly reflects this diversity and heterogeneity among the population. Because behavior and analytic approaches target functional skills rather than diagnosis specific symptom lists, it's well suited for individuals with complex and multiple diagnoses. My colleagues and I have conducted multiple systematic reviews and meta-analyses examining ABA for individuals with Down syndrome, several of which were cited within the reviews that your committee has undertaken. And in our meta-analyses, we have identified high-quality studies that meet rigorous methodological standards, where we see reliable improvements across it. Further, single case designs are not anecdotal. There's replication across participants, settings, and research teams that support population level generalization of single case design. The What Works Clearinghouse, the US federal body responsible for evaluating educational and behavioral interventions, uses a threshold known as the 5-30-20 rule. At least 5 high quality single case studies conducted by 3 independent research teams, including at least 20 participants, means that this is strong enough support for population level conclusions and federal guidance. And there are quality appraisal tools, such as those used in my meta-analyses, that strengthen our confidence in single case generalization to population levels. For rare and heterogeneous populations, single case designs are of strength. They are not a weakness. Where we have low numbers of participants that may be rare, we may not be able to do randomized control trials on these rare genetic syndromes, as well as for heterogeneous populations like intellectual disability. So the full body of evidence, including single case design work, including my own meta-analyses and reviews, demonstrate that ABA is safe, it is effective, and it is an evidence-based approach for individuals with intellectual disability. And decisions should be considered on individual need rather than just the diagnostic category alone, which is consistent with the evidence. Thank you so much for your time. I welcome any questions.
Thank you. And thank you for giving that context.
The last person I have registered is Amy Fellows. Amy, if you could please state your name, any conflicts of interest and affiliations. You have the floor. Thank you.
Great. My name is Amy Fellows, and I have no conflicts of interest. I am a parent with lived experience of an autistic teen who receives DDS services and organ health plan. I was so glad to see that upon review, the HERC staff found that ABA is not helpful for people with developmental needs, intellectual and/or developmental disabilities. I am confused, however, why HERC is not now taking the next steps and reevaluating ABA for autistic children. Autism is also a developmental disability, and your findings were that it is not beneficial for those with developmental disabilities. Why continue to harm one segment of the IDD population? ABA needs to come with informed consent for parents, stating that it is known to cause complex PTSD. I understand parents are often misguided by their pediatricians once there's an autism diagnosis to do ABA, and once connected, the ABA firms try to sign young autistic children up for 20 to 40 hours a week. I have heard stories about ABA techs saying to send the kids to ABA instead of kindergarten. This is not how we should support our autistic children. I appreciate HERC staff's review of the multiple studies and articles that I sent in showing the harms of ABA for autistic children. ABA is a for-profit industrial complex that is about making money, not supporting autistic children. And I appreciate that HERC reviewed these. By your own study, by your own HERC staff report, over the last 5 years, Oregon has spent $215,926,701 on ABA for autistic children in Oregon. Each year, more and more money is being spent. It doubled. I believe it was between 22 and 23. I may have those years wrong. At the same time, ODHS budget cuts are discussing removing parental income disregard through the K plan and even possibly removing all level 1 autistics from receiving DDS services, which includes Oregon Health Plan and in-home community attendant care, home modifications, assistive technology, etc. OHP is important for this population so they can access legitimate treatments such as occupational therapy, speech language pathology, mental health therapy, play therapy, etc. As ABA has proliferated more of our state and it's harder for parents of autistic children or other neurodivergent children to find OT and SLP that is not connected to an ABA center. ABA is now well known to cause PTSD for autistic children that follows them into adulthood. ABA has the same roots as gay conversion therapy stemming from Ivar Lovaas, who created both. Gay conversion therapy is illegal in Oregon, yet we are spending over $200 million on autistic conversion therapy that is known to be just as or more harmful. I understand it may take a change in legislation to no longer cover ABA for autistic children, but it now appears to be discriminatory to continue to cover it when you have determined it is not helpful for other developmentally disabled groups. In the meantime, it needs at a minimum come with a warning label for parents. Please consider taking the next steps for informed parental consent and limiting the number of hours young autistic children are allowed in this abusive treatment. Thank you.
Thank you for sharing your story and for your testimony. Are there any others, Daphne? I think that was 6.
We had 6 people signed up, so we heard from everyone who signed up.
Great, thanks. As a parent myself, we appreciate all the parents coming and testifying. We know, how challenging it is to share your story publicly, and we appreciate you doing so. Okay, so if there's no questions or comments, and we don't have time set aside for an in-depth discussion on this topic today, we can move on. And I think Matt Sears has since joined.
Yes, so we want to make time, as we normally do at the beginning of our meetings, for members to declare any conflicts of interest or potential conflicts of interest, whether financial or otherwise.
Yeah, so this is Matt Sears. I'm a HERC commissioner. As a HERC commissioner, I wanted to note my role with the Oregon Council on Developmental Disabilities, or OCDD, and provided written comments on ABA for individuals with IDD other than autism. As the public policy director for OCDD, I submitted the comments. However, I don't believe it poses an actual conflict of interest in my role as commissioner to consider the agenda topic, as there is no pecuniary interest involved. And while it's related to the mission-driven work of that advocacy organization, it does not impact my ability to consider the evidence with an open mind or to make unbiased recommendations on a personal basis as commissioner. Thank you.
Thanks, Matt. All right, director's report.
All right, so we're gonna thank you all for testifying. So we're going to shift on to other business. If there's no further discussion, I'm going to actually backtrack and give our orientation slides that we always give. We did have some of the public commenters with time constraints, which is why we took that testimony first. This is, as a reminder, this is the Health Evidence Review Commission charged with making decisions about OHP coverage. OHA, the Oregon Health Authority, has set a goal to eliminate health inequities in Oregon by 2030. We're here today. This body is making decisions about coverage for the Oregon Health Plan. These decisions affect over 1 million OHP members as well as their families, caregivers, and providers. There can be no decisions here about individual care. This is not the setting for that. There are processes for that with each health plan, but these are policy decisions that affect those health plans in the Oregon Health Plan. We will, as you know, we just heard public comment. Decisions made here are not final unless approved, and they will be implemented at later dates. In most cases today, that date is October 1st, 2026. There are 2 topics regarding lab tests that would be implemented on February 1st, if you all approve. And that's just because they were limited clinical value and significant financial impacts. And there are a lot of constraints on the state budget right now. And so we felt comfortable recommending those be implemented earlier. In general, the assessments here at HERC, as a reminder, include the balance of the benefits and harms. It's informed by evidence and other factors and expert opinion. Patient values and preferences are considered, as well as stewardship of public resources and different factors about the nature of our healthcare delivery system here in Oregon. Slide. So just some logistical notes. Members, please be on camera and attentive as much as you can. If you need to turn off your camera, please let us know whether you're stepping away or whether you're still listening so we can keep track of quorum and be prepared for votes. And the best way to do that is to direct message Daphne Peck in the Teams, or sorry, in the Zoom chat window, which is available to members. Our votes will be by roll call, as they've been for the past while. And if you want to speak, we encourage you to speak up or raise your hand in the Zoom window. The chat is a little hard to track for those facilitating the meeting. So the raised hand feature or just putting your voice in the room is the best way. We also encourage people, especially those of us here in person, to say our names before we speak. And I know we didn't do that, but it was on the slide. I'm Jason Gingrich. As much as we can, I'd like to shift towards that habit because sometimes it can be hard for those online to know who's speaking. And other participants, and I know some of you have been doing this already, can use the Q&A feature in Zoom to ask questions. And Daphne or another member of our staff will address those as best we are able during the meeting. Anything put in the chat or the Q&A is part of the public record, and the meeting will be recorded and posted online. And our email address, if there's anything that can't be addressed during the meeting, as always, is herc.info@oha.oregon.gov, and we welcome your comments and concerns. And we try to respond within a day or two, so please don't hesitate to reach out if you have any questions or concerns about our work. With that, I'll move on to the staff report. We've got a number of items on the staff report, so this will take a little bit of time. This morning at BBBS, we had the last meeting for David Sanger. And we have another membership, so a couple of other memberships coming that we'd like to vote on and consider for today. One is for Abby Kahn, who has served for a number of years on our evidence-based guidelines subcommittee, to be appointed to move to the VBBS, the Value-Based Benefits Subcommittee. So we have a cardiologist on that group and be removed for BBGS after the February meeting. So there's a February EBGS meeting, and then she would move to the other subcommittee. And also, since Adrian turned out off of HERC, but is remaining on BBBS, I'd like to propose that Ben Hoffman be nominated to serve as vice chair of HERC. If someone would be willing to make that motion. Also like to introduce Jeff Fortner, who is a new HERC member seated, now replacing Adrian. So a little bit of musical chairs. We also have a couple of vacancies. There's a recruitment open for Katie Shables, HERC chair, and BBBS, potentially BBBS chair. And then Linnea's term expired. She's graciously agreed to be here today, but I'm expecting an announcement about her replacement tomorrow, so top secret. But we should have a replacement by the next meeting if all goes as planned. So with that, any questions about membership?
You need the motion to.
Yeah.
I so move that Ben be appointed as the vice chair of HERC.
Second, Jeff Workman.
All right, second. Daphne, could you call the roll?
You got it. Mark Buckholz,
Agree.
Mike Collins,
Agree.
Jeff Fortner,
Agree.
Stacy Geisler,
Agree.
Ben Hoffman,
Abstain.
Max Kaiser,
Yes.
Linnea Lindsay,
Yes.
Larry Lyon,
I'm sorry, I did not hear clearly what the actual motion was.
Matt Sears,
To approve Ben Hoffman as vice chair of HERC.
Oh, agree.
Matt Sears,
Agree.
and Devin Consagra.
Agree, and thank you, Ben.
Yeah, thank you. Thank you.
Motion passes. Thank you.
All right, could we also get a motion about Abby, transitioning Abby from EBGS to BBBS after the next EBGS meeting?
She doesn't want to do both.
So I'll make that motion, Jason.
Thank you. We have a second?
I'll second.
Okay, calling the votes, part 2. Mark Buckholz,
Here we go. Approve.
Mike Collins,
Approve.
Jeff Fortner,
Approve.
Stacy Geisler,
Approve.
Ben Hoffman,
Approve.
Max Kaiser,
Yes.
Linnea Lindsay,
Yes.
Larry Lyon,
Approve.
Matt Sears,
Approve.
and Devin Consagra.
Approve.
Motion passes. Thank you.
All right, that is the membership changes, and we should be pretty stable for the rest of the year. I'm expecting after those changes take effect. Also, we have some staff changes. As you may have or may not have observed, Chelsea Pritchard, our new admin person, is pregnant and will be going on leave any day now. And also, as I told you last time, Liz has gone part-time a couple months ago, and so Tracy Hewlett has joined our staff team. So she'll be backing up Tracy and helping us, or sorry, backing up Chelsea and helping us with process improvement. So watch your emails for Tracy's name and pay rapt attention whenever she reaches out to you. Really glad to have Tracy on our team. She's been at OHA for a long time in a lot of roles, so it's exciting to have her on. Say hi to everybody so they recognize your voice.
Yes, hello, everybody. Good afternoon, and I look forward to getting to know each of you and working with you. So, thank you.
All right. Also have some logistical changes. This is the last time for a while, at least, that we'll be able to meet in this location. As you may have heard, the state is facing some budget crunches, and they're looking for every place we can to save money. The plan at this point is to have an in-person location at a state office building. We're still not sure where that is for the March meeting. There will always be the opportunity to come in via Zoom if it's not a convenient location for you or whatever. but just letting everybody know that we'll have a change in venue for the next meeting. We also have a couple of errata. Liz, could you give that update, please?
Sure. The 1/126 list is the biennial review, which means that the lines got renumbered. And in that renumbering, several CDT codes were erroneously placed on lines like pleurisy. So that's not correct. And so in the change line that will be posted likely tomorrow on the website, you will see a detailed sort of description of what the erroneous line was and what the now corrected line is.
Okay. And then we also have some updates to the public comment survey, some of those requested by you all for the last meeting. So Daphne, could you walk people through those?
Oh, absolutely. Thank you so much. At the last meeting, there was some concern about an option that we'd placed in our public comment survey that allowed people to anonymously suggest or not suggest comments, submit comments. Thank you. We have since changed that to allow for people who are sharing sensitive health information about themselves or another person to select that option. Everyone else, of course, will be sharing on our website. If they don't agree to that, we won't be accepting their comments.
All right, thank you, Daphne. Let's see, the next item. Oh, I wanted to give you an update on the evidence-based guidelines subcommittee. That meeting was canceled in December, so we're starting it up again on February 5th. And there are two topics. One is the hypoglossal nerve stimulation topic. As you may or may not recall, we looked at that a little over a year ago, and EBGS decided they wanted to wait and see if more evidence emerged before they reviewed it. That year passed. They met in September. No new evidence emerged. They approved it to go out for public comment, and then the FDA approved a new device. And so we are going to take it again to EBGS, consider whether that new device will change anything. The staff recommendation will be that it doesn't, but we want to make sure that's considered. Then it will go out for an additional public comment period, be considered again in April, and then go to HERC after that. So a little delay, but still should be implemented by October if all goes as predicted. We also decided, for the record, and stated out loud, that if more devices are approved, we will deal with those separately because we can't just keep moving the gatepost. Any questions about that one? All right, then the other coverage guidance is on insulin pumps that use newer technology that may not have the tubes, may have different sizes of reservoirs, may be disposable. Did I miss anything there, Heidi or Val? Just different technologies that are more convenient for insulin, but are in many cases more expensive. And that will be a new coverage guidance. I think you all reviewed the scope a meeting or two ago, and that will be presented for the first time in February. And that, so that's the EBGS for the next little while. We're also exploring some new topics for beyond that. There's a brief update about dental services. Two of the codes you all approved, D9924 and D9925, which are general anesthesia with advanced airway for dental services, will not be open for coverage. OHA decided that these should be billed with the CPT codes, and that is for reasons that we at HERC don't control or understand. The services should still be provided if anybody needs general anesthesia with advanced airway. It's just they'll be billed in a different way. So I wanted to make you all aware of that.
It's which pot of money it's coming up?
Yeah, it's a different it's administrative within the CCOs.
The services also be provided.
Right. We also have a couple of listening sessions coming up, January 29th. What is the other date, Daphne?
March 5th.
So if anyone in your network is complaining to you or has concerns, or you think they might want to spend some time with staff convincing us to review a topic, that this would be a great opportunity, whether it's a member or a provider. So we'll look forward to those. We haven't had a lot of uptake at the last few of those. We'll see if we get more signups, and we'll evaluate whether we need to change how we do things for those. And last but not least, at our last meeting in November, I updated you that there was some controversy about the benefit update project.
I'm sorry, Jason, you were fading out there. About what?
About the benefit update project. So
Thank
this
you.
is the plan we've been working at for a little over a year, with the end of the prioritized list in mind and the transition to the clinical coverage policies. The work group completed its recommendations, as I predicted in November. I think it was one more meeting after that, after we met. Made its recommendations. One of those recommendations was that the prioritized list be continued if possible. In response to that, the state reached out to the Center for Medicare and Medicaid Services, and we received a response last night. I read it fairly quickly, but the gist of it was that the prioritized list can no longer be used to limit the benefit package in the way it has in the past by moving the line up and down. So, but it can be, the policy you all develop can be used as medical necessity policy, and that's the direction we at OHA had been planning on. There's also been a legislative concept introduced in the legislature for the short session that begins the week after next to change HERC's deliverables from the prioritized list to the clinical coverage policies. And so that will go into the House Healthcare Committee, and we reviewed that bill. The one place where it differs a little bit from what the work group had proposed, I think there's only one place. There's one place that I'm aware of at the moment, is that we had talked about, as we've done the work over the last year, we've talked about what is medically necessary, and we've ensured that those pairings are in place. We had said the funding line is going to go away and it will no longer be an unfunded region. That's all true. That's how the bill reads. There is a section requiring OHA to study whether to create pairings and guidelines specifying what is not medically necessary. And the reason for that would be to reduce ambiguity as to whether HERC had reviewed it and said no, or just not reviewed it. And so the work group had wanted to add that. I think there's some questions about implementation and how to do that that need to be worked out a little further. So that's a study portion. So we'll stay tuned and respond accordingly as that discussion progresses.
What is the study portion?
It means OHA is directed by the legislature to study that issue.
To see if it's possible.
To see if it's possible, whether it's a good idea.
Oh, okay.
Yeah.
Okay.
Any questions about anything related to?
Hey, Jason.
Yeah.
This is Mark. On that note from CMS, did they only state that the line couldn't move up and down in the current state?
The words I remember, and again, I read it fairly quickly and won't try to dig through it, but I'm glad to send you a copy, said that the line cannot be used to scale the benefit package, which is how the funding line had historically been used before 2012 when it was closed.
So, yeah, could you send that? I guess that would imply that if you took out the line moving up and down, then it could be continued. Is that how I interpret that?
Right. Well, I mean, yes. You can. It doesn't say we couldn't call it a prioritized list, but if the line's not moving, I'm not sure why it would be prioritized.
So I think it's the difference between, something that is cost-based and something that's medically necessary. Is the way I've interpreted what CMS is saying, is that you can't make a decision based on the cost, but you can make a decision based on medical necessity. So our clinical input and the way that we put things together and the way we prioritize coverage could still be considered by payers, but we're not setting the benchmark of, and the legislature is not setting the benchmark of the things below this line will not be covered. It will be on medical necessity. And then that's the very simplistic way that I've interpreted what has been being said over the last several months.
Right. In many cases, the same service will be denied, but for a different reason. But that reason matters to CMS. That's the way I've been looking at it. And it's different language for the members, and for the providers and for the plan. So there'll be some getting used to that that'll need to happen. But again, the legislature has not changed our work yet, and we'll see what happens in the legislature. Did that answer your question, Mark?
It did, and I mentioned that because I think in the last 5 years that line has moved from 469 to 472. It hasn't really made an appreciable change in coverage, and it seems like it'd be easy enough just to take out the line part of it.
I mean that. So if we were to go forward with the proposal that's being studied, that's essentially what we would do. It's just that we wouldn't be ranking one line more that is covered, that is medically necessary, as more important than another line that is medically necessary. We'd be essentially having a list of code pairings that are not medically necessary, many of which are currently below the lines, a different list that is medically necessary, which is all of which is above the line now. So it's a lot of semantics, and I know semantics matter, but they matter. In many cases, the end decision will be the same.
In other words, if there's there's a possibility of maintaining a prioritized list, but it's meaningless if there's no line.
Well, it can't be used to scale the benefit package. So if there's not enough money, you can't just raise the funding line. That's the
Which is what the legislature has history.
Right.
Yeah. Yeah. And that hasn't, just to be clear, Mark mentioned the funding line movements in recent years. That's just because we've added and removed lines in the funded region. It's stayed under acquired ptosis since 2012. It's just that we've had a couple lines deleted and a couple other ones added over those years. So the number has changed, but the relative position is the same.
So I want to jump in, Jason. I agree with the comments made that, the line goes away medically. You're essentially going to have the list, and the list is now going to be, the line is going to be medically necessary and not medically necessary. That's going to be the new line.
So to speak, yes.
Yeah. So, and then it's up to the legislature on whether on funding, because when it comes down to funding and whether that 35% state need or state responsibility, then that's up to the legislature.
Right. So there will be a cost. It's currently projected at 0.7% of a very, very large number. That is the state Medicaid budget. There are very smart people working on refining that number and estimating it and managing all the other changes that are happening with the benefit package, filling out, finding ways to address the budget situation we're in. But according to CMS, according to the guidance we received yesterday, it will not be an option to just simply move the line up on the current prioritized list. There will need to be other kinds of changes. Any other questions on that? Okay, and I'm sure I'll have another update in March after the legislature has met and more discussions have taken place. All right, and that is all I have for the staff report.
Right. BBS Do people want a few-minute break? Okay.
But that's almost an hour before we get to the end of.
Yeah, we didn't have a ton of discussion. I think it'll be
good.
relatively
Okay.
straightforward. Yeah, so VBS met this morning. We had our usual consent table, or consent items as a table, some guidelines that had corrections or clarifications, and we removed a code from an uncovered line for a service that an advocate had wanted removed. We looked at the January 2026 HCPCS codes. Just as a reminder for you all, CMS publishes HCPCS quarterly, so this is their January. There were no discussions of any of the code placements except hydrophilic urinary catheters. There was quite a bit of discussion. These are catheters that, when put in water, become very slippery. They're marketed as being less likely to cause infections. The evidence that was reviewed didn't really find that they are significantly better at preventing infections, blood in the urine, or other issues compared to normal catheters, but they are much more expensive. And so the staff proposal was to put them on our excluded services guideline E2. However, there was discussion this morning. It was pointed out that a couple of the studies in the systematic reviews that were presented did find some benefit, particularly in bladder cancer patients because of certain high-risk issues with the type of intra-bladder chemotherapy that they're given. And staff were directed to look to see if we should, rather than put it on excluded services E2, have an ancillary guideline that would allow use in certain high-risk populations. That was tabled, and that you'll be seeing that again. We then talked about new discussion. There were a series of laboratory studies that staff identified that have limited clinical benefit, and there was no discussion about excluding all of them. Either they're not being used or there are other appropriate lower cost or more appropriate tests that are available for the needed clinical decision making. Skin substitute guideline was modified to conform. If any of you have been following the news, Medicare has uncovered a huge amount of fraud, waste, and abuse with skin substitutes. They spent $10 billion on these things in 2024. They have radically changed their coverage guidelines, and we modified ours to conform with the new Medicare guidelines. Nasal polyps and benign nasal tumors, we added specific coverage. It's in our sinusitis guideline that you can address nasal polyps if it's causing sinusitis, but the codes aren't on the appropriate line. So they removed the appropriate line, and there were some clarifications added to the sinusitis guideline saying that they're only there and paired for the sinus issues, not just to treat as a covered condition treatment pair. There was a mistake in your meeting materials. It said that it was effective January 1st, 2026. It'll be October 1st, 2026. Dorsal rhizotomy. This is a procedure where the nerves to the muscles are cut for people with really spastic muscle contractions, like in cerebral palsy. We currently only cover this for aiding in a child's ability to walk. We were asked about palliative, so covering it for caregiving or pain. It was felt to be appropriate. We did the group this morning modified the guidelines slightly from what was in your packet. In the packet, for a general criteria was the ability to participate in rehabilitation. That was actually felt to actually only be appropriate for the group that is trying to gain the ability to walk. The palliative group wouldn't need to participate in rehabilitation. So that clause was just moved to a different section of the guideline. Any questions about that? All right. We discussed nutrition counseling for pre-diabetes. The evidence shows that intensive programs that include nutrition counseling, particularly the Diabetes Prevention Program or DPP, are effective at reducing the rate of development of type 2 diabetes. However, the evidence doesn't show that nutritional counseling in less intensive formats is helpful. We did hear public testimony from the government relations representative from the American Diabetes Association that recommended adding coverage They recommend medical nutrition therapy by a registered dietitian for type 1, type 2, gestational, and prediabetes. But the group this morning felt that the evidence didn't support adding coverage. There is nutrition counseling on multiple other lines of the prioritized list for other types of conditions that can benefit from nutrition therapy. Epithelial on corneal cross-linking for keratoconus. This is a very highly technical topic dealing with an eye condition. One particular therapy, which is the epithelial off, has been approved with a guideline for a few years. The manufacturer of the product that is used for that treatment is not going to stop making that product. And there's a newer product for epithelial on cross-linking, which is more expensive but equally effective, which we haven't covered. Actually, just got FDA approved, so we hadn't actually considered coverage. Is coming on the market. So we changed our guideline to not require it. Instead of saying it has to be epithelial off, it just, that clause was removed. Occupational therapy for ADHD, the evidence doesn't show that it's beneficial and it was not added to that line. Large GI panel tests, these are looking for the DNA or RNA of bacteria or viruses that can cause acute diarrhea. The national guidelines for the Infectious Disease Society, the lab groups, and the GI groups do recommend these tests, but they recommend the appropriate size test. And most private payers and Medicare don't cover the very large test, the 11 and more agents. We moved that test to our excluded services guideline, and then we are continuing to cover the more appropriate smaller size panels. We looked at ColoSense, which is a type of stool testing for colorectal cancer screening. There is only one study on this that hasn't found it to be effective enough to meet Medicare coverage criteria, and we felt the evidence was not sufficient for coverage, and it was added to E2. And then intracranial thrombectomy for stroke, we have added coverage for that service. And then we went on, or first of all, any questions about any, I just whizzed through all that. Anyone want me to go back and discuss something in more detail, have any questions? And then we went on to look at codes that are coming out in 2027, so not effective yet. They're new CPT codes. We typically have an incredibly compressed time to review all the new CPT codes when they come out in the fall, when they're released by the AMA. And I've been looking through the AMA meeting minutes. They have, you can see which codes they are going, they're not actually codes yet. They're sort of we will have a code for this service. And ones where there was a T code. T's are, it's like 0, 1, 2, 3 T. Those are temporary CPT codes, and OHA considers them to be experimental and doesn't cover them, except in very limited circumstances, like that keratoconus cross-linking topic. That actually is a T code. So we do cover them in very limited circumstances. So these are currently T codes. They're going to become CPT codes. I brought it to you all early because this kind of allows you to have a more in-depth review and discussion of these codes rather than discussing 50 different codes all at once in November. And we have a T code to act on. So the ones that we talked about this morning was irreversible electrophoresis of pancreatic cancers, cardiac contractility modulating systems, and fluorescent wound imaging. All of these do not have good evidence that they are effective to treat pancreatic cancer, heart failure, or wound infections, and they were all excluded. So the recommendation is to add them to excluded services guideline E2, which actually isn't going to impact anything for current coverage because we don't cover T codes. When the new codes come out in the fall, I will do a somewhat cursory review. I'll just make sure nothing has been blockbuster come out since it was reviewed in the wintertime, and make sure that the published code matches what we anticipated it would be. And then you'll just have a very brief in the fall. It'll just say these codes you've already decided, and the T code will then be removed from the E2 entry, and the CPT code will be placed if we don't see evidence that there's a need to re-review it. Questions about that whole process? I just did all that header because if you're wondering why we are talking about T codes that we normally don't talk about, especially if we don't want to cover them anyway. So, that was from Gus this morning.
Oh,
We had
all
a
right.
quietish meeting.
Right.
It was all because Ben joined us. He wanted his introduction.
I will take neither the credit nor the blame.
And the labs are effective February.
Oh, I'm sorry, yes.
Yeah.
The laboratory tests that have minimal clinical effectiveness, we are going to implement with that February 1st. We're going to have a very limited new list published February 1st so that we can hopefully see the cost savings without having to impact anyone's actual healthcare.
That's great. Are they, for the lab testing, are they kind of systematically looking at all lab testing? Kind of pick out candidates that are.
I have not systematically, these were all, there were a couple
They
that
just
were
kind of came up organically.
so Marcus Bachhuber, who works for the Center for Evidence-Based Policy, we had him, do you have suggestions of where to look? So some of them came from his suggestions, and then some of them came from going through private payer and Medicare, like what do you not cover, and are we covering it? So yes, I haven't done a systematic look. This was quasi-systematic. So most of them were actually infectious disease tests, which was the most
Yeah, I'm just curious. I mean, it seems like a promising lane to. Okay. Similar to imaging, how does imaging work in that perspective?
That's a
Probably
great
harder,
question.
Because
Yeah.
there's not like a panel.
Yeah.
It's more
Hey,
indication
Ariel.
specific overuse.
Marcus is on the call if you need him.
Yeah, great. And just to thank Marcus again for initially proposing a series, one of which we wouldn't have found at all. We had a combination test that we were paying $20 more for than the individual tests. The same tests. Nobody realized it until he pointed it out.
Nice, yeah.
So thank you. And that obviously will not affect impact. They will not impact care at all. You can continue to get the labs you need. We're just going to pay $20 less. Or, well, maybe if you're ordering them at the same time. So just as some background, going back to that whole discussion of all the new CPT codes when they come out, generally what's been my practice is that when things are lab tests, as long as they don't look crazy, they just kind of are consent. We want to test for things generally. But yes, a lot of them need another look. And then also we've asked internally at OHA, looking for things that are high cost. And, some of those are very appropriate. And they're like a metabolic panel and a CBC, those are huge costs because they're cheap, but used a ton, but we don't want to limit those. There's so many indications and so many situations where,
that would get messy.
Yeah, diagnostic, monitoring labs, checking, yeah. But at least it was helpful to have, these are some top costs. Oh yeah, that's appropriate, that's appropriate. What are we doing with this one? That kind of thing. And we looked into a few of them and we're like, no, there was a series of them that were for vaginitis, a sort of vaginal infections, limiting those, and also for STIs testing and screening, limiting those I felt wouldn't have been appropriate. We want to test and treat, and the ones that were being used and had the highest costs appeared to be the most appropriate tests. So there are a few that if you looked for STI testing, but they were inappropriate and weren't even being used that were in that set. They were like quantifying how much syphilis you have, or that syphilis, like how much chlamydia you have. If you have any chlamydia, we want to treat it. We don't care how much chlamydia you have. So, I've got a whiff. And that one was not being used. But yeah, in our ample spare time,
No,
You
no,
may start cruising through and looking some more.
I know I said they. But I should,
Yeah, and imaging I think would even be more difficult. We tend to review imaging a little bit more stringently when the new codes come out. And there is a lot less. A lot of times when the new code comes out, it's just a modification. It's like with fluorescence or whatever, instead of just, yeah, whatever. EKG, reading and evaluation. So, okay, fine, sure.
Great. Well, thank you.
Since you highlighted that, Ariel, I realized I neglected to mention, there is also a bill in the legislature related to our public comment processes, asking us not to change your agenda within 14 days of meeting and publish comments, not as we currently do, like for the advanced comment packet. We have to publish them within 48 hours of the deadline for public comments. Most of the time we could do that. We're a little bit worried about handling new codes. We may have to have a meeting in December if that bill passes as it is. But I think what Ariel's doing here with the new codes will help make that less necessary.
It's still going to be necessary. So I'm only using things that have T codes. If it's a service that I think might need to be reviewed but doesn't have a code currently.
It'll reduce the number of codes and it'll give more opportunity because these will go out in our advanced materials throughout the year. The manufacturers or other interested parties will have more of a chance to comment. We'll have more of a chance to do in-depth review. So really appreciate that change.
All right. So great. Work. Going on to the decision standards.
Should we take a break?
We're ahead of schedule.
Do you want to approve the report?
Oh, yeah, I guess we have to vote, right?
That's a great idea.
Nothing got it. Nothing.
So I'll go ahead and make the motion to approve the VBBS report.
Second.
Right.
Mark Buckholz,
Approve.
Mike Collins,
Approve.
Jeff Fortner,
Approve.
Stacy Geisler,
Approve.
Ben Hoffman,
Approve.
Max Kaiser,
Yes.
Linnea Lindsay,
Approve.
Larry Lyon,
Approve.
Matt Sears,
Approve.
and Devin Consagra.
Approve.
Motion passes. Thank you.
Okay. 5-minute break.
Great.
All right. Go unplug the truck.
No take backs.
All right, we're ready to get started here. Give everybody a second to come on camera and back to their desks.
Yeah, okay. Take it away, Heidi.
All right, thank you so much, Devin. So for the last part of the meeting, we'd like to have a discussion revisiting the decision standard document that we first published in October as a draft and then brought back in November and had a discussion, and then subsequently have had really thoughtful and reflective feedback from almost all the HERC members, which I'm incredibly grateful for. So I've really taken all of that feedback and come today with what I hope will be a fruitful discussion. Just from the outset, I'll say that, and Liz, you can go to the next slide.
And also, we're on page 226.
Thanks, Chelsea. So for today's discussion, at the outset, I just want to say that the intent is not that we vote on anything today, but rather that we have a follow-up discussion where we can have some focused dialogue about the actual decision-making process. There are a lot of components to how we think about how decisions are made and a lot of processes that lead up to the point in a meeting like we are at today. And so I want to level set for both the public and also all of us, kind of take us through a bit of where we've been and why we're having this conversation today, but then really focus the discussion today on what we think about with regard to decision making when we're looking at a specific issue. So that's kind of our plan for today. So you can go to the next slide. Just to ground everyone. So the purpose of this new decision document is that in your packet, you'll see the current draft of decision standard document that has not changed since the fall, but we've had a lot of subsequent conversation, which has shaped what the discussion today will be. There's also the older document, and that document comes from more than a decade ago and really tried to memorialize in a few pages how HERC makes decisions, and it was time to revisit that. So last year at the retreat, that was a big part of the discussion. And then it's subsequently the two-page document that you see in front of you, that's the new draft, is really a multiple iterations of thinking through what we discussed in the retreat, thinking through how do we make decisions, what do our processes look like, what are we doing now, and what do we need to do differently. And then also iterating it with our evidence vendors, our partners at the Center for Evidence-Based Policy, and others. So the purpose here is really to think about how we make decisions, and in particular, how do we think about equity and health equity in the processes we have in place in HERC, but also in the way that we interact with folks and the way that we consider all of the evidence before us, whether it be peer-reviewed scientific evidence or community input from multiple formats, or looking at other payer policies, or really considering evidence-based guideline or expert testimony. We also really want to ensure that this process is collaborative, and I hope that you will see many of the comments that I've heard from many of you reflected in what we're talking about today. Larry?
Quick question. Where is the prior HERC statement?
I believe in the packet, it's behind the new draft statement. And I can pull up the page numbers here in a minute.
Yep.
Should be the very last item.
Yep, it's page 230.
Page 230. Okay.
Mm-hmm. It's entitled Current HERC Quality of Evidence Statement, and that's just, we put that in there for comparison.
Very good. Thank you.
Sure. So moving on, the other thing I wanted to really ground us in, and I know that we all know this, but just for a perspective of transparency and accountability, we want to make sure that we're all grounded in the same values of the Oregon Health Authority. We are representing OHA in this capacity, all of us, whether staff or whether you're a member of the HERC. And so the OHA values are as stated: diversity and inclusion, health equity, partnership and collaboration, integrity and accountability, and compassion and stewardship. And so it's important that in everything that we do in HERC, processes, outputs, products, engagement with interested parties, all of that reflects those OHA values. Next slide. You've also all seen this a few times too, but I wanted to again bring it back and say that while I know that there's feedback from many people about specific components of this definition of health equity, this is the OHA definition of health equity, and this is the definition that we need to reflect in our work. Now, what does that look like in the context of the HERC scope of work? That's precisely what we've been working on for almost a year on this decision standard document, and what I hope we have a specific discussion about today. So this is the definition that grounds us in thinking about that question. How is health equity a part of what we do in HERC, and how do we consider it in the decisions that we make, the processes that we set up, and that sort of thing? I'm not going to read it to you because I know you've all read it. You've all heard me read it to you in various capacities, but it's here. We can refer back to it during our discussion if needed. So the other thing we want to just ground everyone in is that we all know that OHA has a very broad scope. These are the divisions. If you go to our website, this is what you'll see, all these different divisions. And then within the divisions, there are so many different potential places where work is being done. I mean, not potential, but work is being done in all these different places. And if you look at the org chart, it's very complicated. There are a lot of different components. There are a lot of different examples of things that happen. There's Medicaid implementation, there's food inspection, there's licensing board, there's patient care at state hospitals, and I could go on and on and on. I just tried to, Jason and I brainstormed a few very practical examples. And these things, for the most part, are out of the scope of what we do here in HERC. And the point of this slide is to say that we are one part of a very large, complex, dynamic health system and we can impact pieces. We have a sphere of influence, but we cannot impact everything. And so it's really important for us to consider how we do our work. How do we do our work in reflection of those OHA values within our sphere of influence in HERC? Next slide. So, zooming back down, big picture, coming back down. I know that this is well known to all of you, but just to, again, make it clear to the public as well, we review medical evidence and create guidelines about health services. We decide what should be covered for the Oregon Health Plan. We just had a lot of conversation about a lot of different policy changes that have happened or are on the horizon, but at the end of the day, that's what we're trying to do. We review in-office procedures, surgeries, behavioral health services, some medical devices, therapies, different imaging and lab tests, some dental services. And we have a commitment to a public process that is a reflection of accountability, and we hope to do it in a way that represents trustworthiness to the public. We want to be sure that that's what we're doing when we're making these decisions. Next slide. So this is the list of subcommittees and advisory panels, and it's in here just, again, to make sure everyone's on the same page. I know that people in the room are, people in the virtual meeting are, but there may be people watching who don't know that all of these things fall under HERC. So thinking about what is our scope of influence, well, we have these different things that happen at these different cadences, and these are the kind of topics that things may come up through. Next slide. So bringing us back to the earlier original slide, the purpose of this is to outline for ourselves and for the public how we do our work and how we consider health equity in the context of our work. Next slide. So in the decision standard document that was in the materials and in the one that you saw previously, this has not changed. I just want to remind folks that we have these 5 key questions. We discussed many of these in the November meeting. We ask, is the service or the issue being reviewed clinically meaningful? Does it have clinically meaningful benefits? Do those benefits outweigh the harms? Are they of equal or better value than covered alternatives? What are the effects on health equity? And is it feasible to implement? And there are multiple sources of information that you see are feeding into these 5 questions. Those include, and you can go to the next slide, peer-reviewed science, and these are not in any specific order. There is no hierarchy here as far as choosing the way they are. That's why they're flat on that other picture. Peer-reviewed scientific evidence in our enabling legislation, that's clearly important. Community feedback from lots of different interested parties, also a part of the enabling legislation and critically important. That includes Oregon Health Plan members, many of which we heard from today, families, caregivers, advocates, and multiple ways that that can be presented through verbal testimony, through written testimony, through listening sessions, and ensuring that all of those have accessibility for anyone who may have a difference in wanting to present, but may not be presenting, in a particular way. Like if they can't get there, we have a virtual way to present, but we want to also be sure that that's also accessible. So that's really important. Expert opinion, clearly that comes from clinical guidelines. Staff frequently pull clinical guidelines if we can find anything that's relevant. And also sometimes it's individual clinicians, or sometimes we have subject matter experts that weigh in on particular topics, either in meetings, prior to meetings, or during coverage guidance development. And then we look at other policies, including other state Medicaid policies. Next slide. So, what are the health equity considerations for HERC? And the reason I'm zeroing in on this particular question is that's the question that had the most discussion at the November meeting. And this is the question for which I've had the most feedback from members about how do we think about this? And one thing I can say in looking back through all of the feedback that staff have received, that health equity is considered a foundational principle that really critical for all the processes that we have in HERC, how we design them, ensuring that we carry them out with integrity to that principle, and that we continually improve them. That's something that has come through loud and clear in numerous interactions talking about this. The other piece of this is that we're trying to be as practical as possible about how we consider health equity during review of information and decision-making processes. So that's what I really want to spend our time sort of focusing on today. That first piece, health equity being a foundational principle, I'm going to talk about just for a couple more minutes. That's that overarching principle using an equity lens. You can go to the next slide. And so health equity, an equity lens in the context of HERC, what does that look like? Well, it's a framework through which we design our processes. We consider very intentionally the impacts of any of the things that we're viewing on populations that are a part of OHP. And it's also a way to think about or frame discussions about systemic inequality that are related to services that we're discussing. And so many of these things were brought up by members as they reviewed the decision standards draft. And this is really how we're thinking about this work broadly. And for some, that isn't more of a theoretical exercise. And my hope today is that we recognize that we're trying to weave equity into all the ways we design processes and the ways we look at continually improving them. But we also want to be very practical and clear about the ways that we're weaving equity into the decision-making processes that come in the output of all those processes. At the end of the day, what we give you in a packet, how do you make decisions and how do you consider equity in those decisions? All right, next slide. So that's what I'm hoping we can focus on for the next rest of the meeting here. So when we get to a decision-making process, how do we consider health equity? And many of you have given incredibly thoughtful feedback that's very practical. We are really working hard to make sure that we engage with plain language, that the very technical jargon that comes in our issue summaries and coverage guidances is translated into real language. Daphne does an amazing job at that. We try as a staff team to do that. That's one way we do it. We try to have multiple ways of engagement, which I mentioned earlier, with all interested parties. We want to treat people with dignity and respect. It takes a lot of time and energy to come and provide testimony, and that's critically important for us to understand lived experience. Like we heard today, much lived experience was shared today, and that's such a gift, and we want to honor that and accept that experience that's shared with respect. We also really try hard to ensure we're looking at bias in the way that evidence is, studies are designed, the way that evidence is presented, the way the methodologic data are presented. We try hard as staff and our evidence vendors try hard to ensure that the bias that potentially is there is clear to you as you're deliberating. Furthermore, a lot of times populations that are, being reviewed in literature aren't necessarily the populations that may be those represented in the Oregon Health Plan. So we really try hard to think about those pieces and present you with those as well. None of that is going away. None of that is changing. In fact, we want to continue to do more of that. But what I'd really like to focus on today are really those things, the additional things that perhaps we can do to set up a discussion that's very intentional about health equity when we're thinking about a specific decision that needs to be made. And we really want to focus that on the sphere of influence we have here in HERC. And that can be hard. There's a tension there, but that's really, I think, the work before us. So these are the things I would ask you to consider. Are there ways that staff can assist with processes or providing relevant information for you to consider in deliberations? Some of you have given very practical guidance about that already, but I wanted to have a further conversation. Some have also suggested that we have a consistent list of questions that we consider in deliberations to ensure that health equity is being considered in our decisions. And there may be other things that you've thought of since you gave feedback over the last couple months. So my hope is that this is where we can go next. And the last slide is this is a list of questions that was developed by looking at suggestions from some of you and looking at other best practices when people are considering equity and trying to use a very intentional process for considering equity in population health policy decisions. And so these are just suggestions, but in a standardized or structured way, may be a way that we can potentially assist in providing an intentional way for equity to be considered in decisions. So I said a lot there. There's a lot to unpack, but I hope that the level setting helped you all to recognize that, as a representation of OHA, we're trying to reflect those values in authentic ways, and we're trying to use the equity definition, but use it in the scope of context here of HERC. And Jason, before we open it up for member discussion, I just wanted to see if you had any other thoughts. I'll go back to next steps at the end. If you could go back to the questions, I'll wrap up with next steps at the very end. Thank you, Liz.
Yeah, I just wanted to appreciate the immense amount of work Heidi has done on this, as well as most of you met with us since the last meeting, and we really appreciate that, especially during the busy time of year. And also encourage us, how do you say it? So the equity statement, OHA, as Heidi observed, has all kinds of different pieces and parts. Hopefully, in each of those parts, we're addressing some portion of that health equity. But the state hospital is not going to be addressing Medicaid coverage, and the public health division's food inspection unit is not going to be impacting diabetes care. We're not going to be impacting food inspection or language access, even within the Medicaid program, is not something that's in HERC's purview. So even though that health equity definition is really, really broad and covers things in all of those different areas of OHA and many more areas beyond OHA, food, housing, education. Our work is very focused. And so we're not going to be able to hit all parts of that health equity definition in our work. And I think saying we can't do that can be really helpful because it allows us to focus on the places where we can have a really important impact on this work. So I encourage us, as we have this discussion, to think, okay, these are, these questions and others you may bring or you brought up in our one-on-one conversations, they all intersect with the health equity division definition at OHA in one way or another. None of them hit it all. How do they intersect? How would they affect how you make decisions, how you listen to the presentations from our staff, how you listen to public comment, how you review materials, how you process that information, how do we already apply that so that we can document that clearly and hold ourselves accountable to that? How might we improve our processes, our transparency, our accountability, our intentionality about applying these principles and knowing when they do and do not apply? So that's what we're trying to do here. And then finally, we're never going to get perfect on this. We want to get better. We want to be better, and having whatever we can come to consensus on in the next few meetings will be a step. And we'll probably find some places where it doesn't work. It'll be a living document. So with all that in mind, I'm looking forward to hearing all of your thoughts.
Yeah, thanks, Jason. And if folks in the room, if you could just remember to say your name. Generally, I can figure out voices, but sometimes people who are further away from the mic, it's harder to hear. And I want to make sure I'm capturing everyone's feedback. So I'll open it up. And really, I'd love to be as practical as possible in this conversation. How can we make this happen? How do we do this? And what can we do as staff to support this?
Hey, Heidi, this is Mark. What exactly questions are you asking? And I mention that because on your first slide, I'm going to shoot all the way back to that stewardship statement. And I'm not sure if that's up for discussion.
Yeah, so you're talking about the OHA value of stewardship.
Yeah.
Liz, can you flip back to the OHA values? Thanks for being the master of the slides today. Okay.
Yeah, I understand about, everything is fairly straightforward. The compassion and the stewardship part, that can have different meanings to different people. What exactly is the meaning on this for OHA values for HERC for stewardship?
Yeah, I think that's a reasonable component of the discussion. I think what's not up for debate is whether or not we adhere to these values, but and the equity definition. But what I do think we want to have a conversation about is how we understand them, both the values and the equity definition, in the context of our work in HERC. So I would welcome discussion about what members think about that, or any of the other values and how they apply to HERC.
And as we do that, I'd like to ground that in our definitions, our rules of both state and federal. about providing the least costly alternative service that will meet the members' needs. Also services not principally for the convenience of members, which those are words people argue about, believe it or not. And how we apply that in the context of our work, where we're making decisions for, some conditions affect a dozen people in Oregon, others affect 1 million. And so welcome your thoughts about that. But those are kind of, and not principally for appearance is the other word. And those three are kind of the space we work within that relate to stewardship. Cost effectiveness, we're also required to consider in statute. So just wanted to throw those principles out there because they're ones we talk about as we prepare the materials.
Mark, could you say a little bit more about why you asked about that? I agree, it's an important question, but I feel
the reason I asked about it is because it's on this slide, but it's not on future slides moving forward. And given the state of affairs currently, and in transparency representing insurance companies implementing these decisions, would like to make sure that it is fiscally responsible for the tax dollars and whatnot. And so, that was the rationale. Does that make sense?
It makes a lot of sense. I just wanted to give you an opportunity to kind of say more about that. I mean, in my mind as well, I think the idea of stewardship is closely linked to the idea of equity because, you can't approach equity for the entire population as socioeconomically disadvantaged. If we're not mindful about stewardship, we threaten access for broad populations of people, all of whom have needs.
I have a question. I'm going back to the OHA definition of health equity, and what I'm reading is Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by race, ethnicity, language, disability, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. When I read that definition, it makes me ask the question, if a lawyer were reading that, does that create an opening for anyone who feels that I didn't reach my full health potential and well-being, and therefore I am going to somehow file suit against the state because I didn't, however they define their full health potential and well-being, does that create that type of opening?
If I may, real quick before Heidi responds, just so we can make sure we get to those questions. My understanding is there's nothing we can do about this definition or its existence. It's there, so we don't have any purview over wrestling with this definition.
So the reason I take your point. I agree. I have, yes, but the reason why I bring this up is when I look at the current definition, it looks to me like the current definition actually is part of this proposed new definition. And with the addition of taking into consideration input that, for lack of a better term, maybe is not as rigorous in a scientific sense. So I guess what I'm saying is that the current definition, and then taking into account the additional questions that we're asking sounds like would be reasonable. So I'm I guess I'm a little puzzled why are we making more out of this than is necessary? And I also agree with Mark's question about stewardship. That I think that is an important definition, because that also fits into this, because if we're talking about equity and health equity, that not only does it mean different things to different people, but it also, in my mind, creates a certain standard for what we need to do.
Yeah,
Right.
thank you. Sorry, Devin, go ahead.
No, go ahead.
Yeah, no, thank you very much, Larry, and thank you for your feedback and talking in depth about this as well last week too. I think it's important to recognize that we are reflecting the OHA values, and this definition reflects one of the OHA values. What we're trying to do is be as pragmatic as possible about how we operationalize that in our HERC work, and how can we be authentic to all of those OHA values, stewardship included, in the work we do at HERC. And so this was simply to ground everyone in, this is the definition. We are stewards of the work that OHA has put in front of us. And so we need to reflect that, but how do we think about in the context of HERC? So I appreciate your feedback. Mike?
Thanks, Heidi. So let's look at this OHA health equity definition and understanding that's what it is, right? We're not gonna have the legality issue of reach their full health potential and well-being because of the next sentence or the next part of the sentence. It's not a or, it's an and. You have to, people can reach that full health potential and well-being and are not disadvantaged by all these other things. So they go hand in hand. You have to have both of those in order to prove that you're not reaching your health equity definition. And if you read it closely, it's not saying that everybody's going to get there. It says that we're going to create a system that can get you there. That's what this statement is saying. It's not saying everybody's going to have health equity and reach their full potential of health. It's saying we're going to create a system that can get you there. You still have to put the work in as a patient. You still have to put the work in as a person.
What happens if you don't get there?
Well, yeah, go ahead, Devin.
So I just want to kind of keep us on track. So Heidi did such a great job of kind of pointing us in a direction. So I just want to make sure we get there. Could you pull up the slide with the questions on it? Sorry, I don't mean to interrupt, but I feel like we can talk conceptually forever about this because it is such a deep concept. But we'll be here forever if we do that. So I think as much as we can, trying to think about the broader concepts as they apply, as Heidi so nicely put it, practically, what does this look like for HERC and the work we're doing? How could we operationalize it? And, yeah, go ahead, Ben.
This is Ben Hoffman. I just, for clarity, in that definition, Oregon will have a health system. We're specifically talking about OHP, correct?
We and HERC.
Yes.
Right.
Correct.
So we're broader than that.
But our constituency are people in Oregon who are covered by OHP.
That's our purview, yeah.
And we're already starting out, like that population is overwhelmingly kids who are the poorest part of our population. They're more likely to come from minoritized and marginalized communities. So we're not starting with an even playing field. And when we're thinking about that definition, we need to think, we need to superimpose that definition on the population that we are charged in supporting, which is a different conversation than all of Oregon.
Absolutely. I mean, I think we've kind of heard this several times now, which is this idea of health equity as applied to a population, that if you were to put this population in the context of the broader population, would already be a population that is identified as, having needs or being disadvantaged in some way. So how do we, so operationally, how do we reflect that here? I mean, there seems to be something about, this is kind of an issue for this entire population, right? In the context of healthcare in Oregon overall. And so how do we think about these questions with regard to that? I'm not sure how to.
Larry, if I can just frame this a minute and then I'll come back to you. So one of the things I want to stress is that the processes that we have in place, we have tried to embed practical reflections of health equity in those processes, in the way we review evidence, the way we report it to you, the way we interact with interested parties, the way we provide accessibility, the way that we come with particular we advance notice, those sorts of things. Like we've tried to embed very practical reflections of what health equity things might look like for HERC. But what I'd like to really move us to is to really try to think about what can we do to help you as you're in the decision-making process. Because there are periods of time where you may not have quantitative evidence that really maybe as much as you want. We talk about issues that may not have multiple randomized controlled trials that give you the quantitative information that you're used to seeing. So in that situation, and we may present you a lot of trials that don't reflect the population that is reflected in OHP, to Ben's point. So my hope is that we can talk about these as, is this one example of what we could do to systematically consider equity in an intentional way? I heard from many of you that you want to ensure that we are intentional in thinking about health equity in decision making, but we don't want it to be a checkbox that everything that comes before us, yep, we check the health equity box, right? That's why a structured list of questions was, I think, recommended by several of you. And I did some work trying to look at what other groups do around this. This is just one suggestion for what we could do when we bring things to you in a decision-making capacity. That is not taking away any of the other things that you suggested and that we already do in the processes leading up to this. So that's what I'm trying to get at is, if it's not this, maybe there are some other things that we can do to help these conversations be efficient, but also intentionally occur.
I wonder if, Ben, I don't want to put words in your mouth, but in getting back to your comment and thinking about these questions, just kind of a question for the group. I mean, there may be two layers to this, right? I mean, one can imagine a question that gets at Ben's point that might be something like, how does this evidence relate to socioeconomically disadvantaged populations or to Medicaid populations, generally speaking, because we're going to be looking at evidence that is not Medicaid specific, and then trying to apply that evidence to an OHP population writ large. So that's not so much about groups within OHP, but it's about how does the evidence apply to populations that might resemble OHP. Again, I don't want to put words in your mouth. Is that kind of what you're getting at?
No, because I think a lot, there's a huge evidence bias that exists around kids in general, and minoritized populations in general, not based on race necessarily, but more sort of social economic drivers of health. I think the way that we think about, the way that I think about, at least for me, I think about these issues is different when I'm starting with a population that is already disadvantaged. I mean, I came to the HERC because there was no voice for kids, no voice that focused specifically on kids here, and had not been for a period of time. I want to make sure we don't lose that we've got Yeah, and I think that that's really what Heidi is trying to get us to think about, is how do we start with the mindset of who our constituency is and what their unique needs are that might not be represented in discussions that occur about the broader, the entire state population.
So I think to pull us back to what the conversation is, OHA's description of health equity and some of those pieces are set. They aren't things that we are going to affect in this conversation. What I hear Heidi asking and what I heard in the discussions was, how do we include this lens in our conversation? And to Ben's point, I think it is, how do we articulate the potential biases of the data and the research and the information that's given to us? How do we note it that this was only done on 54-year-old, purple people eaters, and it wasn't, it's not inclusive of the entire population. So I think one of my thinking, even though I'm on the way out, that EGBS will certainly need to, from the evidence-based guidelines, we will need this kind of lens, is that if data or information is presented to us, that there's a notation that has clarity of the potential biases in the data, or the potential, the risk of generalizing the information to all persons covered. And that's what I would like to see in, like, I was even suggesting, like, we have these grade tables. Could we have this additional kind of column or table or set of information that just kept that awareness and centered us in acknowledging that research is potentially biased, and that data is potentially biased, and that we're not getting always the whole picture, and it's fluid. So there's a lot of things, but how do we quantify, articulate that information so that in the decision-making process, we are acknowledging and centering our thinking around our potential participation to be co-opted into perpetuating bias because we have a naivete or a lack of awareness that's the benefit of the staff being able to pull that piece in. So from a very pragmatic standpoint, I would prefer to have information provided that acknowledge that when data is presented to us.
If I'm understanding correctly, I mean, that's a great point. And I wonder, Heidi, if that would be captured in kind of more robust discussion around applicability or generalizability. I mean, so theoretically in the grade construct, the concept of applicability is there in the indirectness kind of part of that, but it's not always pulled out or discussed. That it could be more. So to whom is this data most applicable, right? Could be a question that is posed of the evidence.
Yeah, and thank you, Devin, and Linnea. And I think one of the other things that I heard in feedback was that sometimes it would be helpful to contextualize the scope of the problem within Oregon and then within OHP. That would be helpful information at times for people in their decision making. So not just looking at the evidence before you and whether there's generalizability or what we would sometimes call external validity toward the OHP population, but what does that scope of the problem really look like for the people that we're trying to help in this process? So I heard that from prior conversations. Stacy, and then Larry, I know I saw your hand up too.
Yeah, thank you. Great discussion. One of the things I'm sure all of us or many of us review for our specialty area journals. And one of the criteria that we have for mine is actually a table where we make assessments as to generalizability. And I was thinking about impact factors. You know, we rate articles based on their impact. It's interesting. I wonder if we could somehow develop a scale that would make an assessment. In my small group with Heidi, we were talking about assessing disease burden, the impact of the disease for given populations, making notations as to whether certain groups have been studied. So I think that we could develop something that could be very succinct, and it would be more work though for the staff, using some different measures of population science.
Thank you for that. Larry, I'll come back to you.
Yeah, you know, I'm hearing a lot of very interesting and very good points. And one of what I am thinking is, especially, and I think I'm going to attribute my thinking to being stimulated by Ben. There's an elephant in the room, because when we talk about health, health does not exist in isolation. It exists, health and healthcare, they exist in context. And as Ben said, the OHP population has some significant disadvantages compared to other populations. And what I'm wondering is, are we trying to factor in social determinants of health, health-related needs, socioeconomic status? Are we factoring in those things? Because I think those are really the things that I think we need to bring to the fore, and how they affect people's health and the health care that they get. And I think that that is a very reasonable thing to consider, exactly how we do it, and where is the data that will give us that information. Or if we don't have some type of rigorous scientific process to give us that information, how else do we get that information, and how do we factor it in? And I like what was just said about figuring out what's the impact.
Thank you, Larry. I also can't see the room, Devin, so there may be people trying to speak. I can only see you and Jason.
Yeah,
And
no,
far
no,
away,
hands
Linnea.
here, but please jump in.
Can I make one more comment?
Yeah, of course.
So this is Ben again. I think that, and I had mentioned this when I had my conversation with Heidi and Jason. The pediatric population also lives within a statutory mandate around EPSDT that is not, that does not have to be considered for adult populations. And I don't see that in the questions for possible decision-making consideration. We're working up, it's federal statute that anything that anything that is medically necessary and appropriate must be covered by Medicaid. In Oregon, we have statement of intent 4, which states that medically necessary and appropriate for kids includes anything that will allow them to grow, develop, and attend school. Those are criteria that do not exist for the rest of the OHP population. And I think, we can't, if the rules are different, we can't, and the criteria are different, we can't have the same processes for separate population, for the different populations. Yeah.
So that's a really good example. So I'm trying to get real practical here as we prepare reading materials. So let's say we have a topic. So we acknowledge that OHP has more kids, more people, low income, facing lots of disparities due to race, ethnicity, societal expectations, all of the above. And we have a particular topic, XYZ disease, which may disproportionately impact kids or adults or older, or people of a certain gender or, whatever. So if we acknowledge the relevant parts of what I just said for a topic, so one question is, how is that going to impact your decision making? Because what's relevant for us to include depends on that. The second thing is that what you just mentioned about kids, I think an EPSDT is one way that the federal government actually, and OHA belatedly, have recognized that kids do have different needs because of development, and the ability to attend school is going to impact the life course and the developmental pathway and whatever. And so the fact that that law exists right there is reflecting some portion of health equity. So are there similar things we should be considering or doing with other topics, that are specific to a population with heart disease or diabetes or obesity or broken bones or, whatever it may be? That, I think that's the question for us. Some of that, we'll be looking at insulin pumps for type 1 diabetes, disproportionately kids, although there's an increasing adult population. Right? Like, how does that change your decision making? And should we just state it and let you figure out what's relevant? Should we be doing that work ahead of time and deciding for ourselves? How can we help you make better decisions along that axis of who is impacted? Because every topic's different, right? Has a different combination of those factors.
I have a question. So Heidi, can you give us an example of something that might fit into what we are talking about?
Well, Larry, I think with an equity lens, what I heard from many of you is that you look at health equity as a foundational component of everything that happens in the HERC sphere of influence, everything that we're doing, that's a foundational principle. But then when we come to decision making on a specific issue, that there may be information or ways of presenting information that would be helpful for you to consider that's issue specific. You talked earlier, Larry, about contextualizing health and healthcare. So in some issues we present to you, there may be an important contextualization. I think, Stacy, that's also what you've brought up a few times. That what is the incidence in Oregon? What is the incidence in this population of OHP? And what other context can we provide that would help you think through equity considerations on the service that's before you?
Right. Can you give just for the sake of illustration, can you give us a specific something that we can say, okay, how would we look at this?
Yeah, so do we want to just talk about insulin pumps for a moment? Right. So we cover insulin pumps. I'm foreshadowing a little bit, but do we cover insulin pumps currently? Yes, we do. For type 1 diabetics, we cover tubed pumps or traditional tubed, many synonyms for the same thing. Basically, an insulin pump that's attached to a tube has a reservoir of insulin, and that's currently covered. But there may be groups for whom that tubed pump is not the best for them. So a young child, for example, right? So that would be a consideration that gets at some of the points Ben was making earlier about children. So young child developmentally is going to be pulling on a tube, right? So that consideration may be something that we really need to think about for that particular population. Just to be super concrete, that's one example.
Yeah, thank you. That's what I wanted. Concrete. Hmm.
Yeah, and I appreciate everyone wrestling with this because there are no easy answers here. There are a lot of bioethical tensions in all of this work that we're trying to do. And we're all here to make a difference and try to ensure that people get the care that they need and they live healthy lives, high quality lives. And ultimately, that's what we're trying to do. So I appreciate that you're wrestling with these issues because if this was easy, we'd have written a 2-page document and you'd already approved it and we'd have moved on.
Can I go back to the concrete for just a minute? So let's say there is a kid who has an insulin pump and it's a tubed insulin pump, and he pulls the tube out and there's no way of getting him to alter his behavior? And could he have a tubeless pump through an appeal process?
Yeah, so that option already exists. There's always that option, the exceptions process. But what I was sort of giving you an example of, the coverage guidance that we're looking at right now is asking that very question. Is there evidence that we can say certain subpopulations may need this more than others? And instead of having exception after exception after exception, is that something that we bring forward to say, oh, it seems like this makes sense in the context that this group maybe would be able to have these pumps? Like that's just an example. We haven't done that yet, and certainly it hasn't gone through the process, but I'm just giving you an example.
Let me
You know,
follow, let me follow up on that example for just a second. Okay. Could the exception process be captured, or the number of times that it occurs be captured, and then to use that as a way of changing the particular policy on, for instance?
Yeah, it's a great,
I
great
think Jason
suggestion,
has
Larry.
a
Yeah, I just answered.
response.
Yeah, go ahead, Jason.
Well, thank you for raising that, Larry. It's actually a good point. I actually have new access to data for the PA requests for different services. And so if you all, that's a great example of something we could look at. We could say, how many requests were there for this, you know, type of insulin pump for kids under 18 or whatever. You know, we have limitations. We can't do it for every topic comprehensively, but that's the kind of thing we could do.
Yeah, and that's what brought this
How you
whole
are
thing up, Larry, too. Yeah, I mean, like this whole thing came to us because Ariel's sitting on a committee with a bunch of exceptions around the pumps. So and I know you were trying to talk, and then Stacy has her hand up too. So I'll pass it back to you, Devin.
Stacy can go ahead, but just as we're, you know, because I think we've already getting a couple examples of specific questions we can ask. I think let's keep track of these, but or somebody is. But I just wanted to highlight. I just wanted to highlight that is an example of a specific data point that we could look at, and then just to make the analogy with the insulin pump example. I mean, it's interesting because I don't know that we labeled it health equity, but there's been many examples of meetings in which that kind of consideration comes up. And it's often, you know, the expert testimony or others, you know, it's kind of the practical, what does this look like in different people? So a good example is the chest vest discussion we had. I'm not sure how many of us were there for that, but you know, there's all these exceptions, and it's like these kids with neuromuscular disorders, there's, you know, too few of them to study, and you hear from the pulmonologist, yeah, they really need this, and you know, because the, you know, parent can't sit there and do this 5 times a day, right? And we took that into consideration and ended up approving it for those indications purely on the basis of these kinds of considerations. So that was a consideration that's already kind of baked into the process, but maybe we haven't labeled it in the right way. So maybe we can give some thought as to what to call that and kind of list it here, because I think maybe sometimes we're kind of doing some of the work and just not, you know, quote, getting credit for it. Stacy?
Yeah, you know, this is going back, and maybe I'm viewing this too simplistically, but if there was a table, if you knew that there was a behavioral issue or developmental issue, rather than going through this whole complicated exception process, you would just say, you know, we're going to take this group of people because of this very obvious problem and, you know, funnel them into this certain treatment category. So anyway, I kind of like objective, simple things that you apply to populations. I think it could streamline some of the decision-making process.
Yeah, that's great. Yeah, Mark, and then and then Ben, and then Larry.
Yeah, this is a question. I'm intrigued on the exceptions because working in the UM work, we have hundreds, if not thousands, of exceptions. And I know all the CCOs do the same thing because all denials need to go through a physician reviewer. Do we keep track on the OHA side of all of the thousands of exceptions to learn which ones might be beneficial just to streamline? I guess that's a
Yeah.
question for Jason regarding the data and the thousands of exceptions.
It's not quite that term. So when a PA request goes in, say a 6-year-old child, physician orders a insulin pump, they have type 1 diabetes. There's a record of that request and whether it was approved or denied. And so I have some, I don't have all the granular information about whether it was why it was denied, but I have some relevant information. And so that's something I'd actually like to explore. How can that contextualize our decision? And I have a feeling it won't answer all the questions, but it might answer some of them.
But it might also be a way, I mean, this has come up periodically in discussions, but this idea of, we make a decision and, sometimes we're kind of making an educated guess because the evidence is not perfect and we acknowledge that. And there's a desire by many in the group to revisit a decision or be informed, kind of post hoc as to how it plays out. So there's the contextualization for the decision, the initial decision, but that kind of information could also be useful a year after the decision to see what happened, right? We did this and, we limited it in this way. And then it turned out there was like 10,000 exceptions and they were all getting approved and it was just a waste of administrative time.
Yeah, that's a great idea.
Right. Ben.
So I'm sorry if I'm sounding like a broken record. I think under the questions that we're looking at, we need to specifically address whether or not EPSDT would apply because we have different levels of leeway outside of EPSDT. And I think that, I think if that were there, my angst would decrease a significant amount.
So you mean literally just does EPSDT apply?
Yes.
Okay.
So how would that work? So if it does not apply, you might think about exceptions a little more.
Yeah.
Maybe a more detailed policy than you would for a child.
Right, because that then gets us, so, for an adult, I don't have to worry, maybe I do need to worry about grow, develop, and attend school.
I see.
Right? But that we need to, because, and some of this is because we spent, there's a generation of Oregonians who did not benefit from EPSDT. And if we're talking about equity, this isn't reparations, but it is ensuring that going forward, kids are not discriminated against in the way that they were. And I'm not saying that to make anybody feel, I'm not saying it's what it is, just saying that's what that is the situation.
Okay, we get
Thank you.
Ben, and then I think Stacy.
Where's Larry? I think was next.
Or is Larry? Oh, I didn't see your hand.
Yeah.
Sorry, forgot.
I want to go back to what Mark said about stewardship. Okay, because it sounds I'm getting an impression here, and it sounds like on the one hand, we want to be proactive, which I'm going to conflate just for the sake of discussion into predicting the future versus acting on data, capturing, for instance, PAs and exceptions, and then using that to create a path forward. And I'm uncomfortable with predicting the future because I don't know that we're very good at that. And then again, because it goes back to stewardship, because the wise use of resources is, I think, extremely important, especially in current and I believe future economic times. And this is also what the HERC does is it's an iterative process. So if there is new data that comes up, we can act on it. it's not a perfect process. And I really think that the enemy of good is perfect.
Mark, did you have another comment or was your hand just up from earlier?
Hands
I
down.
have a question for the group, if it's all right. One thought exercise that might be useful, we probably all have different levels of confidence or comfort or agreement with decisions HERC have made. And if you think of ones that gave you pause, or you weren't sure about, or you disagreed with, and then you look through this list of bullets here, I wonder if that might elicit areas where we could be providing better information so that you could feel more comfortable with the decision, that it's a good decision. That just might be a helpful exercise, because if you say, when we reviewed XYZ widget and we decided not to cover it, if I had known that it affected this group of people, I might have made a different decision, or that the group of people experienced this kind of disproportionate barrier, or that, additional contextual information. That's the kind of thing that would really help us as we prepare our meeting materials, and if we have a standard set of questions or whatever.
Yeah, I mean, I think that part of what we're doing is breaking some of these questions down into some more specifics, so that for example, this insulin tube discussion and the chest vest thing, special, practical considerations that are applicable to, I don't know what the term is, practical use considerations, or, special populations. And it gets into, both those things, the insulin tube with little kids that pull out the tube, and chest vests, for parents that can't do BT all the time. Those get to be kind of parachute-like examples in terms of evidence, right? The answer is in the physical practicality of administering this treatment in this subpopulation, if that makes sense, right? We arrived at those decisions because it's kind of obvious when you start to think about it for a subgroup of people. So I wonder if we can reframe some of these, or, does the, is the, how is this intervention used practically in different subpopulations? Or are there certain subpopulations who might especially benefit from this intervention because of their specific needs or whatever? I'm not phrasing any of that in English that makes sense, but we can figure it out. Earlier, I think Heidi had made the point, I think Heidi had introduced an idea, and we kind of left this thread about data that would be helpful. And I think you were mentioning epidemiologic data that might be Oregon specific. And I think I can speak for the group in saying, yes, that would be super helpful. Like if we knew, here's this topic that's coming up, it affects X number of Oregonians, and it's anticipated to affect, mostly young people, or, mostly old people, whatever, that would be super helpful.
I'll give credit where credit is due. That was Stacy. Had brought that up a few times. Awesome suggestion. And as a public health person, I was all over that. I was like, descriptive epidemiology, we're on it. I can't promise, but it's, I think, a practical consideration that we can think about. Another suggestion that came from some of you was thinking about how we could better collaborate across OHA, for example, with other parts of OHA that perhaps we don't have a sphere of influence on it, but maybe they do. And sometimes we already do that. When we come across something, we direct someone across to a different part of OHA. But are there ways we could do that with data, maybe around public health? I don't know, but I'm willing to explore that with Jason's.
I mean, just to double down on that last piece, Heidi, that you stated, I think that's incredibly important, particularly when it comes to implementation of services, which is not our purview really. But I would argue that a lot of what we do in terms of health equity impacts ends up being operationalized through implementation considerations. Just the ABA discussion earlier, we're not discussing it now, but in my mind, a huge part of that is an implementation kind of discussion, right? Is it the massive cost of it versus the need? The sweet spot answer might very well be, how do you implement it? How do you do it responsibly where it doesn't cost a ton, but people that really need the service can get it? If there is a way for us to interact more with the people that would be responsible for that, that would be amazing. I think the closest example I can remember of that was the out-of-hospital birth discussion we had, and because that had a lot to do with implementation, and I think we discussed that a lot. Anyways, I'll stop blabbering, but I wonder if one of the questions might be, and again, we might not be able to affect the outcome of the answer, but are there implementation considerations that might improve access to this intervention for broader populations, or reduce inequities, or however we want to frame it?
Great. Yeah, great thought.
Stacy?
Yeah, I don't know if this already exists, but it'd be cool to have an impact factor for these decisions. And we wouldn't know initially necessarily all the things we'd be looking at, but we would over time refine what criteria, metrics are going to give us the best predictability for helping people. So you could have an Oregon impact. I don't know what you want to call it, but you're trying to develop a simple thing that people can understand, that's defendable, that legislators will understand. Yeah, so that's all.
That's a great idea.
Stacy, can you say a little bit more about what would be in the impact? Like what kinds of information?
I know, I think we should listen strongly to the concerns of the people on our commission that are concerned about children. But I think, I think of disease impact. I think of if there's interventions. I think about the economics of these things. The developmental concerns, if you have a group that developmentally is not going to do well with the intervention, the treatment, the Medicaid, you just are going to put them into a different path. Yeah, is that helping? I don't know if I'm helping at all, but
yeah, no.
Yeah, in our small group, Devin, we were talking a little bit. We were talking about dental caries and the impact that it has on kids and all these different factors, right? They're in pain, they can't go to school, they can't eat, they can't focus.
Oh yeah, I'm sorry.
Yeah.
That helps. So I'm just trying to get at the word.
Yeah, another example would be Black women and screening for breast cancer, outcomes related to breast cancer, right?
Yeah,
there's disparities, and I think if we're talking about equity, I'm not an expert on this, but I think the simplest way of explaining how we're looking at things, people can understand this. And so disease burden, outcomes, if historically there's groups that have not been studied, that's something that probably should be considered.
Yeah, I wonder if one way to get at I theoretically, we do this already, but we could call it out more in terms of the type of impact you're describing, I think would come at the topic scoping phase, where you're choosing your critical outcomes and your important outcomes. That's another way of thinking about what the expected impact of the intervention is. So in your example, maybe somebody that doesn't think about dental caries all the time might not think to make that an important outcome of whatever. But, you know, if you hear information that says, oh gosh, you know, this is actually a critical outcome because it has all these downstream consequences and could be treated as such. But that may be one other practical way we can get at health equity in our processes is in the topic scoping phase, is in thinking about how we rank our outcomes.
Is there a way we can come back to a future meeting with some actual data? For instance, something having to do with either prior authorizations or exceptions for a particular or what kinds of things are there needing or people requesting exceptions or PAs for, so we can actually see, have a concrete example of here's what's happening in real life, and to actually connect that to what Stacy is suggesting, which is to, okay, what kind of impact might we be thinking that is going on here?
Yeah, I think, Larry, as you said, this is iterative, and I think our hope is to get these suggestions from you and to go with the ones that are the most practical at the outset, where we may have data for them. Others may take us some time to develop relationships, perhaps across, OHA or other types of data. We might need to see if it exists or it's available to us. But I certainly think, Jason has got this new part of data, and he had, mentioned earlier that he's wanting to take a look at that. So I think we certainly can do this, and we welcome ongoing suggestions. I have one final question for you as we wrap this up, and I know we're getting near the time of ending the meeting. So thank you for this really helpful discussion. This part is around the impact of public testimony, public comment. A lot of what we hear are people's lived experience related to the issue that's under review. Sometimes that issue may not even be on the topic, on the list of topics for that time. But how are we, so I'm not talking about how people are getting to us. That's Daphne's doing an amazing job of developing out those processes and having those be an equity grounded way. But I'm talking about when we're making decisions and we're considering public testimony, public input, and the lived experience piece. I just wanted to see if there were any other insights. Many of you already shared those insights, but like with these questions in mind, or when we're in this decision-making piece, how do we think about that? Because part of this is about, we have a lot of power in the roles that we have, whether it be staff or whether we're in a decision-making seat. And so thinking about what is that responsibility and how do we handle, that sort of data, that sort of input. So I just wanted to throw that back out for any other thoughts that anyone may have around that.
I was quite struck by the testimony about applied behavioral analysis today, both in terms of positive and also negative. I thought that really made me sit up and pay attention and made me think I would really like to know more about this.
I think I see a hand raised in the distance.
We need to acknowledge that access to the ability to the agency and ability to provide testimony is inequitable. And we hear from people to whom something is important enough and they have that agency, they feel enough power to be able to participate. And we don't know what we don't know. We don't hear from the people who we don't hear from. So it's really hard. Like the power of story and of anecdote is undeniable, but the plural of anecdote is not the truth. And how we reconcile that, I struggle with that.
And the percentages aren't necessarily representative of where the voices would be.
I think that's what I'm trying to say.
Yeah, I mean, it gets tricky. I mean, we've had situations where, you'll get an advocacy group and get 10 people lined up around the right thing, or, yeah, I mean, it seems like one way of getting at values and preferences, right? it's not the complete way, but it's a way, and I think we all find it valuable. I mean, we've given all these examples, right? Chess Fest, all that. I mean, part of the way we learn about these practical, it's a pain in the butt to do this. And here's what it looks like for my kid or whoever. We learn about that through the testimony sometimes, and that's useful. Panda pans, originally we were going to ask for two, specialty consults, and I think we heard from enough people that said, practically speaking, that's impossible to do. We don't have access to doing that, and it would neuter the whole recommendation, and hence we took that requirement away based on that. So I think there are practical ways in which the testimony can and has influenced what we do. I wonder, this is a different thing, but getting back to Mark's point about stewardship, I wonder if there's room for a question that's the converse of this, right? That's something like, what is the expected impact of this decision on the availability of coverage for OHP writ large? I mean, basically, it's a financial impact kind of question. But I think it relates to equity, because if we approve coverage for something that costs $50 million, it's $50 million that is not available for all of the other things that might affect health equity. And I wonder if we can link that idea of stewardship with health equity by asking about that.
Essentially, the opportunity cost.
Yeah, basically, yeah. Well, it's not even just an opportunity cost; it's a cost cost.
Right.
But yeah. The idea of opportunity cost, yeah.
Well, covering this now,
right?
Lose an opportunity.
Exactly. Yeah. Right.
Any final comments? Anyone wants to share before we wrap up and I talk about next steps?
Do you feel like you got enough?
Yeah,
from this
I do. Yeah, I do, Devin. Liz, can you go to the next slide? So I really genuinely, when I say this, I'm grateful for everyone's time over the last few months and the thought that you've put into this and the reflection that, and many of you have sent written comments. So my hope is that, I felt like it was necessary for us to have another synchronous discussion, public meeting where we could talk through some of these issues, be as thoughtful as possible about the practical considerations, given that we are limited in some of the things we can do, but that's not an excuse not to do this well within the influence that we do have. And so I really appreciate the discussion today. I have compiled all of the feedback that I've gotten. I took a ton of notes today. I'll probably go back and listen to this a few times. My hope is that a revised decision standard document will be to you fairly soon. So you can provide additional input and feedback. And then my hope is that we'd be able to bring this back for a conversation that takes us to the next level and how to actually get this, voted on, that this is kind of what we're deciding on. We have some shared understanding of how we're moving forward together, recognizing that, as many of you have said multiple times, this is iterative and we're not going to go 10 years and not revisit this document again. But I think we'd like to get it to a place where we can put it out for the public, not just in a public meeting, but on our website, as this is what we've agreed upon at this time about how we're trying to operationalize these questions, how we consider different forms of evidence, and how we engage with lots of interested parties, and how we make decisions about medically necessary things that continue to come in front of us. So I appreciate this. Any last words or any other thoughts on this, Jason, or any other HERC team want to share anything else before we finish this part?
I just again want to express appreciation. It felt like we got really practical today about something that can be pretty heady and abstract and sometimes more emotional than practical. So I really appreciate the thought you've all given. If you have, something that comes to mind in the coming days, please reach out to me or Heidi, so we can put that in the hopper as we take the next steps, bring this back in March.
And Heidi, thank you for being so thoughtful about this. You're doing amazing work. We appreciate it.
Thanks. It's a team effort. We're all in this together. Thank you.
With that, are we done?
We are adjourned. Next meeting is ready to adjourn. The next meeting is March 19th. Location to be determined. We will have an online option, but we'll probably have a location either in Portland or Salem for those who want to come and can't come in person. We got people from different
No, I
places,
know.
so we'll have to. We may be doing a survey.
Did we approve the HERC minutes?
Oh, no, my fault. Sorry.
Thank you.
Before you run away, my fault. Totally failed as
That is on
chair.
page 6.
Yeah.
Thank you for
Thank
keeping
you,
us on
Tracy.
track.
Yes.
You're hired. Oh,
I
wait.
was like, wait, did I miss it? Was I sleeping?
No, you should fire me as chair. I missed the meeting.
You have to be a chair for another year now.
All right, does anybody want to move to approve the minutes?
So moved.
All right.
Second.
Okay. Do you have to call the roll or?
Yeah.
Yeah, I had to do the voice
Yeah.
vote, but before I do that, I just want to say we didn't just hire Tracy. We went out and got her.
Yeah, that's right.
Good job.
Mark Buckholz,
Approve.
Mike Collins,
Approve.
Jeff Fortner, Stacy Geisler,
Approve.
Ben Hoffman.
I'll abstain because I was not present.
Oh, okay. Max Kaiser,
Yes.
Linnea Lindsay,
Approve.
Larry Lyon,
Approve.
Matt Sears,
Approve.
and Devin Consagra. Is it Matt or Matthew?
Matt.
What do you prefer? Okay. All right. Thank you. Motion approved.
All right, thanks, everyone. Oh.
Okay.
You all
See you
look
guys.
very cold in there. Everyone has coats on.